Well, thank you very much. It's a pleasure to be sharing my lab's experience today with you. So we'll be discussing Amplicon-based NGS panels in practice, covering three major themes: routine diagnostics for solid tumors, an expanded NGS panel workup, and copy number variant detection in gliomas. Here are my disclosures related to today's presentation. And also, I am a recipient of a grant from Thermo Fisher. So to set the context for the first discussion, I want to tell you a bit more about our lab here at London Health Sciences Centre, or LHSC, in particular the molecular lab. We are a public lab serving a large regional catchment area covering both constitutional and oncology genetic testing indications. So you can see in this table here the rough testing volumes of the last 2 years with the solid tumor NGS and hem-onc NGS split out there. So all of this just to say that we are a pretty high volume, very busy lab doing many different things. So having a very streamlined NGS solution is really critical to the proper functioning of our lab. In terms of solid tumor testing, we do follow a province-wide standardized approach to molecular diagnostics. So this has been developed in recent years through a governmental organization, Cancer Care Ontario. I'm not affiliated with them, but CCO, along with experts from the community, identify diagnostic, prognostic, and predictive biomarkers for specific tumor types. And so these biomarkers are the genes that we are testing for in our solid tumor NGS panels. The panels that we test here at LHSC are listed in this table, so you can see the disease site, the particular indication, as well as the genes included in that panel. You will notice for any individual panel, we are testing like a handful of genes. They're not very large panels. They're very focused panels. And in terms of the workflow, when a sample arrives at LHSC, it's first going to the pathology lab where the pathologist will review the sample and order NGS testing if it meets that indication, as well as any other required ancillary testing. They'll also assess for tumor cellularity and perform macrodissection if necessary. After the sample is run through the lab and we have data to analyze, we classify variants according to the ASCO-CAP AMP guidelines, and we are only reporting tier 1 or tier 2 variants. In addition to the panels listed here, patients with advanced cancers also have an option to register for a research trial, which gives them access to an expanded gene panel. And we'll talk more about that in a few slides. So when it comes to choosing an NGS solution, of course, there's no perfect assay. There's many factors to consider. So I told you a bit about our lab, but if you were in this situation, you would also want to consider, among other criteria, potentially testing volumes, target turnaround time, resources, both human resources as well as financial and capital equipment and so forth. The breadth and the depth of sequencing required, so how many genes and how deep of a coverage required, the patient population, and the tissue types required. So for us, with all the details I gave you, we selected a mid-sized Amplicon-based NGS gene panel, which combines hotspot coverage for oncogenes and full gene coverage for tumor suppressor genes. This panel covers over 100 genes. We also couple this with an Amplicon-based RNA fusion assay, which targets about 50 fusion driver genes. For today's presentation, I'll only be discussing the DNA panel, but just be aware that we are also offering that fusion panel for many of these patients. This panel takes about 5 days for library prep and sequencing. We run samples in batches of 8, and we're able to run approximately eight batches per week, and that's with 2 or 3 technologists on that bench per week. We have a target turnaround time of 14 days. On this slide, you'll see all of the genes included on our panel. And now in blue are the ones that are actually part of one of our solid tumor panels. So of course, you can see we're only reporting on actually a minority of the genes that we are capturing and sequencing. And so we're doing in silico slices to report out on those solid tumor panels. But the genes in black do give us some flexibility in case any of these genes are later added to a provincial panel, and they're also available for that expanded NGS panel. A few years ago, our lab published our experience with the first few years of testing. So this covers the time from July 2017 to May 2020, including just over 3,000 tumors. In the table, you'll see the 4 of the more common subpanels that we test, including the genes that were on those panels at the time. So I think all of these panels have since been updated to include additional genes. And on the right, you'll see the number of patients that tested positive for tier 1 or tier 2 variant. We're going to focus on lung cancer or non-small cell lung cancer for the next couple of slides. So I'll point out that 69% of this cohort tested positive for a tier 1 or 2 variant. On the left here, we can see the particular genes that the mutations were, the tier 1 or tier 2 mutations were identified in. So over 40% of our patients had a mutation in KRAS, including 15% with the targetable G12C mutation. EGFR mutations were identified in 11% of patients. And on the right, you can see the different range of mutations identified. So of course, we see some of the common hotspot mutations, such as the leucine 858 arginine substitution, but also various exon 20 insertions and exon 19 deletions, as well as some patients with more than one EGFR mutation. And so while targeted subpanels capture high yield mutations, patients may have actionable mutations outside of standard algorithms. And studies have shown that expanded NGS panels can increase diagnostic yield, especially in advanced or metastatic tumors, rare subtypes, or patients eligible for clinical trials. However, expanded genomic profiling is largely inaccessible for most patients in Ontario at this time. So our lab explored the utility of an expanded gene panel through the POWER study, which stands for Precision Oncology at Western University. This is a single center study led by my colleagues, Dr. Beckham Sadikovic and Dr. Stephen Welch, where we are using a mid-sized NGS panel. So it's about 100 genes. It's not comprehensive genomic profiling, but it's still broader than standard of care panels. And importantly, this study was designed to prospectively assess clinical and overall health system impacts of expanded testing on patient management in a real-world oncology setting. This was done through the use of pre- and post-test surveys where clinical teams had to answer questions evaluating the clinical impact of genetic variants that were identified. So here's what we found from the first 385 tumors where the surveys were filled out. Almost 80% tested positive for a clinically relevant variant, so tier 1 or tier 2. 34% had a variant that potentially changed their management. This figure here shows that breakdown in some of the different disease sites that we test. So again, just focusing on lung, we can see that in purple, there was 45% of variants that potentially changed management and 82% that had a clinical impact overall. 8.8% had a variant of unknown significance and 8.8 had no variants at all. Digging into a bit more this question of using an expanded versus a tumor-focused subpanel, within this cohort, there were 162 patients that had prior testing with a small tumor-focused panel. Of those, 96 patients were positive for a variant by that smaller panel testing, compared to 144 patients that were positive for a variant based on the POWER panel. And overall, there were 109 variants that were identified by the POWER panel, but not by that smaller panel. And in 19% of patients, those variants actually had a potential impact on patient management. So you can see the variants that were identified by the clinical teams as potentially having an impact on patient management here, which were not identified on the standard of care panels at the time. In terms of the treatment options, so it was noted that 28% of patients became eligible for additional treatment options after the POWER results, either through clinical trials, off-label drug use, or compassionate access programs. There were also broader health system impacts noted. So 15% of patients had access to a safer treatment. This treatment sequence was changed in 17% of patients, and the Ministry of Health formulary treatment was saved in 13% of patients. So here's an example, a case example where patient management was impacted. This is a 55-year-old male with an advanced stage colon adenocarcinoma. By immunohistochemistry, the mismatch repair status was intact. The colon NGS subpanel was negative for any reportable variant. And at that stage, the patient enrolled in the POWER study, and we reflexed to the larger panel, which identified 2 tier 1 or tier 2 variants. We have a POLB2 single nucleotide deletion resulting in a frame shift that was identified at a variant allele fraction of 53%, and an ERBB2 missense variant, a serine to 310 phenylalanine change at 40% variant allele fraction. This is a recurrent, well-known oncogenic mutation. According to the surveys, this ERBB2 or HER2 missense variant did impact this patient's management. So they were now eligible for off-label drug use, so a HER2 inhibitor through a compassionate access program. And this also meant that they could avoid chemotherapy, which was instead saved for any potential future progressions. So with this expanded POWER panel, about 100 genes, we identified clinically actionable variants in about 80% of cases, and we changed management in about a third of patients. But I think that naturally raises the question of how does this, like what else could we be missing? And how does this panel compare to comprehensive genomic profiling or CGP? I think in the field, we're increasingly facing this question of how broad of testing is broad enough. And so everything I've been discussing today really fits into this first column of small to mid-sized panel, whereas comprehensive genomic profiling would really be multiple hundreds of genes or even exome and genome sequencing with the main, what at least I consider would be the main difference is the ability to identify these tumor agnostic genomic biomarkers such as microsatellite instability, tumor mutational burden, and so forth. So this is really not possible with these small to mid-sized amplicon panels unless they're specifically designed with that in mind, which ours was not. On the other hand, from a lab operation perspective, that these small panels are really great. So very little DNA is required. Degraded DNA generally is still works very well. Because the genomic footprint is smaller, you can multiplex more of the data storage, and the analysis is really streamlined for the most actionable mutations. And all of this results in a lower cost per sample. On the other hand, if there was a new gene to be added to a panel of interest that wasn't included in your panel, you now have to do a spike in validation, which can be additional work. In comparison to comprehensive genomic profile, this should be relatively easy, assuming that gene is already being captured as part of the standard workup. And then finally, for CNV detection, CGP generally has pretty good genome-wide CNV detection. And with the small panels, it can either be more limited, so just to the regions being captured, but also can be more challenging. And I think it's important to point out that certainly both approaches have value, and which solution should be selected based on laboratory considerations, of which we've talked through a lot, but also the clinical scenario, testing access, and therapeutic implications. Okay, so for this last portion of the talk, we'll move on to talking about gliomas, and in particular, looking at copy number variants or CNVs using the same amplicon panel. So both single gene CNVs as well as larger segmental aneuploidies, such as whole arm or whole chromosome changes, are really imperative for an integrated glioma diagnosis according to the World Health Organization criteria. The particular CNVs of interest are listed in this table. So we have 1P 19Q whole arm codeletions. This is required for a diagnosis of oligodendroglioma. Then there's trisomy 7 with monosomy 10, as well as EGFR amplification. Both of these are molecular features of grade 4 glioblastomas, so supporting that diagnosis. And then CDKN2A homozygous deletion will change the grade to grade 4 for astrocytomas. At our institution, most glioma tumors were getting both NGS to look for sequence variants, as well as FISH testing for these specific CNV biomarkers. Unfortunately, a few years ago, we were having delayed results from our FISH CNV reporting. And so the opportunity came up to see if we could call these CNV biomarkers from our existing NGS panel. CNV detection by NGS is, of course, already well established, but it can be more challenging with smaller amplicon panels. And with this solution, we do use a read depth approach. So just very briefly, where the coverage of reads to a specific locus is used to infer either a deletion or a duplication of your region of interest. We designed a custom analysis to use this panel to detect segmental CNVs. So in this slide, we'll walk through the example of a 1P deletion. So using standard software, we obtained normalized gene level copy number variants for all genes in our biomarkers of interest. And so for all of our biomarkers of interest, we'll take the average copy number of all the genes in that region, so all the genes in 1P. But we also look at the average copy number of a control region. And for 1P, that control region is chromosome 1Q. So for all of our biomarkers, we're looking at the absolute copy number of that biomarker and also the ratio to a control region. This is pretty simple, and it's also quite similar to how FISH analysis is done for these biomarkers. Through our validation studies, we identified two sets of thresholds. One is a stringent threshold where a CNV could be reported directly as positive from NGS. So this particular example would fit that criteria. It's clean and it's well below our established cutoffs. But we also have a more lenient threshold, which will identify more like gray zone or inconclusive samples where there's still some uncertainty whether it's really positive or negative. And for those, we do still reflex to FISH to get an accurate answer. And then if neither of these thresholds are met, we can report negative from NGS and skip the FISH in that case too. And just quickly here, highlighting why we think it's important to look at that ratio to a control region. Again, looking at chromosome 1P. In these figures here, you'll have the FISH results on the x-axis, where each dot is going, or shape is going to represent a tumor sample. So in this first column, these samples tested positive for 1P deletion by FISH, as did the patients in the second column, but it was a relative deletion. So there was a deletion with polysomy 1. And then in the last column, patients tested negative for 1P deletion. On the left, on the y-axis, we have the average copy number of the 1P region based on our NGS panel. And you can see most of the patients with a deletion are separated fairly well from the normal or negative patients, except for these three tumors here who were found to have a relative deletion by FISH. And so when we switch over to this figure on the right, and now the y-axis is showing the ratio of 1P to 1Q by NGS, we can see that those three samples are now being rescued essentially by this ratio. So they're falling in the same range as our other deleted samples. And overall, through our validation studies, we had very good results. with near 100% concordance. There was only one potential false negative by NGS for a CDKN2A homozygous deletion. This was a very low level deletion, like in a very low number of cells by FISH, and it's still being worked up as it may also represent a false positive by FISH, but I included it here nonetheless. The other important criteria, though, aside from concordance, is the reflex rate, as this tells you how tight essentially we can be with our cutoffs. So you'll notice, for instance, trisomy 7 and monosomy 10, we have almost a quarter of patients still need to reflex for that biomarker. But I will point out that most of them are turning out positive when we do reflex to FISH. So as we accumulate more data, we think that we'll be able to kind of tighten those thresholds. And importantly, from an operational perspective, since adopting this strategy, we've seen an 87% reduction in FISH assays that need to be performed. So this is a really big win for our cytogenetics lab, as now those technologists can be working on other critical assays that lab is working on. And for both the pathologist and for the patient, this is resulting in faster turnaround time for the CNV biomarkers, as well as a faster integrated diagnosis, ultimately. Okay, so the key takeaways from this lecture are that small to mid-size amplicon-based NGS panels are a pragmatic solution for routine solid tumor testing. They're high yield, fast, and cost-effective. They can also be used to perform expanded NGS testing in patients with advanced cancers. And we have shown that we identify additional clinically actionable variants. And this has an impact on treatment decisions. And finally, with this panel, we were reliably able to detect CNVs, though having robust validation data is really important for benchmarking these segmental aneuploidies using a targeted panel like this. So at this point, I'd like to thank you for your attention and also acknowledge all of my colleagues at the Molecular Diagnostics Lab at LHSC. They're the ones who kind of keep this workflow running day in and day out, as well as my colleagues involved in the POWER study and the glioma CNV studies. Thank you.